I would like to invite Dr. Sarfraz Baig for the next talk on tips and tricks of laparoscopic sleeve gastrectomy.
Yeah. Thank you very much. So this is a video which is going to play on its own. So I bring greetings. Is that playing? It's still showing 1 second. It should play. Yeah, it's playing now. It's playing now. Yeah. So bring greetings from my hospital. And I'll be talking about laparoscopic sleeve gastrectomy tips and tricks. It is the commonest bariatric procedure. The reasons are that it appears to be physiological. There is access to GI endoscopy. We believe that there is less nutritional complications and the data suggests so. And there is equivalent efficacy as gastric bypass. Some believe that, but a metabolic effect probably is inferior to gastric bypass. But in any case, it is the commonest procedure. The indications are you can use it in diverse situations. In young patients where you don't want to do a bypass, in an elderly patient where you want to have less sarcopenia effect, prior to organ transplants, concomitant with hernia surgery. If it's an inflammatory bowel disease or the patient is on chronic medication, you want to not alter the GI tract and absorption, and you can use that. Preoperatively, we prepare with a glycemic control because quarter of these patients are diabetic. Liver preparation with a very low calorie diet so that the liver can be lifted up, very important technically. DPET prophylaxis, cardiopulmonary status optimization, stopping antiplatelets, and spirometry so that the patient is well prepared before the surgery. And that goes true for all bariatric procedures. Now, this is the standard thing that we use. A very steep head up is very important. Surgeon stands in the middle and the cameraman on the right side. But there are surgeons who would stand on the right side and the cameraman will be in the middle, and that's also perfectly acceptable. The important thing is to realize the patient will be in the steep head up position so that the hiatus can be seen. These are my own port positions, which many surgeons probably do the same thing. 5 port just below the xiphoid and towards the left 2 for the Nathanson retractor, 10 for the camera in the midline are skewed to the left a little bit, 12, 1 roticulating stapler coming from the right side so as to minimize the number of large ports, and that's the surgery that we will talk about. This is a young female with 55 BMI. And we have put in the Nathanson retractor. The most important thing about any bariatric procedure is sucking the stomach. And that's the most important thing I feel in all my foregut surgeries, to make sure that the fundus has been sucked up very well so that the entire stomach lies flat in front of eyes. Then we start with the opening the lesser sac from the opposite the incisura and getting inside the lesser sac. Now this is done typically opposite the incisura because if you go more to the right, you have a chance of getting into the gastropeploic. If you go to the left, then more needs to be done later on. So this is an easy way, and this is the place where the epiploics are furthest away from the greater curve. You can err on the side of the stomach because as it is, you're going to resect that. So having those burns in the stomach doesn't make any difference. But staying close is important, and as soon as we start going towards a splenic side, it is important to do one of the two. Either use a ligature, which is a better sealer than the harmonic, or use a harmonic at a lower setting like number 2. Also, you can do something which is called harmonization. You can harmonize on the left, then cut on medial to that. So there's like 2 strokes on one plane. And then when you go to the top, remember the sleeve gastrectomy efficacy works best if the entire fundus is taken off. So that is the separation from the spleen that is being done. And then you get on the left cruise. As Dr. Bharti rightly said, it's important to see the entire left cruise. And you can see here that the fibers of the left cruise can be seen. And it's not only important to see the top part of the left cruise, you have to see the apex of the left cruise. So this dissection is important, and there would be some vessels typically coming from the retroperitoneum onto the G junction. And if that is divided, you will have a very straight sleeve. So that is one picture out there. Remember, we will not be firing on the esophagus. So having that thing right in front of you is important. When we go down towards the pylorus, it's important to take this this division plane by plane. So see it as a two layers, like this stroke is the top layer and then one is a deeper layer. In that manner, we tend not to have bleeding from those large gastroepiploic vessels. And if you have to push in the bougie till the duodenum, better to do this more than less. But if you are not going to put in the bougie for the first fire, you can stop at least about 3 to 4 centimeters prior to the pylorus. Now here the first fire is very important, and you have to be about 3 centimeters from the pylorus. That's our standard practice. And then from the incisura, it has to be wide. A narrow incisura is a recipe for disaster. It can lead to leaks. So having a wide incisura, like 2 times the bougie size, you can see that I haven't put the bougie yet. And then, so the 2 ways. One, fire the bougie over the bougie, the first fire, but I would recommend for beginners to always pass the bougie till the duodenum and then fire. Always check for the crotch staples so that there is less chance of misfires, and I will be showing a video on that. So I'm not showing that step, but you can see how straight we are going. If you see, the most important thing that you want to do in a sleeve is wide incisura and keeping the sleeve straight, no spiraling, no spiraling. And that can happen with good retraction either from lateral side, but if it's a very heavy liver, very low space, then only probably just a retraction from the surgeon at the intersections. Now once you do that, you have the entire thing in front of you. Now this is controversial, some surgeons will do it, some will not, but remember the most problematic thing about sleeve is the leak which happens at the G junction. So that happens if the fire has been on the esophagus, but what we do is we always keep a shoulder, about a centimeter of a shoulder on the away from the G junction, so that the staple is on the stomach and not on the esophagus. And number 2, we always oversew the proximal staple line. We do not see merit in stapling, oversewing the entire thing, but this swing has to be Lambert, seromuscular, not through and through. We are using a 3-0 PDS, and we are moving from top to bottom to invert the staple line. Now there are reports and the literature to show that the reason why it happens is because the high pressure zone, and there is ischemia. So by inverting this, probably we may be circumventing that. So no hard data on this, but this is something that we have been doing for since I think the last 10 years, and we haven't regretted doing it. So it does take a little bit of a time in the end, but having done that, it always feels secure. You would have invaginated a little bit of the fundus also if you left something behind, and that is good for all of us. So that's the process. We generally do a methylene blue test, but these days recently we do it only selectively. We do it routinely in a bypass, but for a sleeve, we do not see much of a merit to doing a methylene blue test all the time. And then this sleeve is extracted through the 12 millimeter port. So in this patient, there's only one 12 millimeter port on the right side. Post-operative care is clear liquids for the first 12 hours, and then patient is put on a liquid for 2 weeks, and then they undergo cardiopulmonary assessment. DVT prophylaxis is given to high-risk patients for about 3 weeks. Glycemic control is maintained, and we start with the chewable tablet of multivitamins about a week later. What are the tips and tricks to a sleeve gastrectomy? First of all, I'll show you a horrible bleed that happened about 10 years back, but has made me very wary. That was a Belsey pad of fat, and there was a time when we always used to excise the Belsey pad of fat. Fortunately, those practices have gone, and you can see the amount of bleed that happens in the hiatus. Not easy. And why I'm showing you is, this is what you don't do. Don't try to catch that culprit vessel now. It is much easier to do the sleeve, take out the sleeve, see that area much better, and then use a bipolar cautery precisely to do it. Here what we are doing is we haven't done a sleeve gastrectomy, and we are still trying to do it. And what we will do is, we will probably harm the stomach fundus more than needed. So don't do this. It's good to just put in a pack, do the sleeve, see that area much better, and then tackle it. And of course, the second thing is, don't excise the Belsey pad of fat, just reflect it. Now these are hypertensive patients, many of them, and many of them are on antiplatelets. So there was a time when we used to apply hemostatic agents like a snow, on these staple lines, even when they're dry. I don't think I do that these days, but yes, whenever we see patients with some ooze and patients on antiplatelets and with issues of hypertension, we think that, okay, this is something that we can use. This is a very important thing. We haven't checked for the crotch staple and we fired. And probably we didn't fire well. Now you see what has happened. All the staple lines look pretty bad. They're all bleeding. Now this is again recipe for disaster. So what we did was finish the sleeve with the second and third firing. Then we started suturing from the top. And then we invaginated all of this faulty staple line in this stage. Now, earlier I would have probably panicked and would have probably addressed that issue at that time, and I think that wouldn't have been a great thing to do. It's better to finish the entire thing, take one suture or two sutures and then do it. Nowadays we have the scope of using barbed sutures, and they also make life very easy. And this patient did well. So I'll just wrap it up with saying some take-home messages from sleeve gastrectomy. It apparently looks simple, but there are nuances. And those nuances are to keep the wide incisura, keep the sleeve tube straight, fire away from the G junction, and we also think that if you can put lemberts on the proximal staple line, it will reduce your leak rates. So that's from my side. Thank you very much, the chair and the audience, for your hearing.
Excellent talk, Dr. Sarfraz. If there are any questions from the floor?
It's a simple procedure.
Absolutely. Well done, sleep. So yes. I think Dr. Sarfraz has covered everything and touched upon all the controversies about whether to suture or not to suture, whether to do a leak test or not, in the brief but exhaustive this thing. Thank you, Dr. Sarfraz.
Thank you, Dr.